I would say the one thing we do consider to be a specific risk of PFA potentially is the issue of haemolysis, and if excessive haemolysis exists, then potentially renal failure or increase in creatinine, things like that can occur with that. That's something that we've started to see, but really once you understand it and understand how to minimize it, I think it can be managed fairly safely.
Welcome to Rhythm Interventions Unplugged, your monthly deep dive into the world of electrophysiology. Join us as we explore the latest research, share clinical insights, and provide practical tips to keep you at the forefront of your field. Now here's your host, the Director of Cardiac Electrophysiology at St. Bernards Medical Center, Dr. Devi Nair.
Hello everyone. Welcome to another episode of our podcast. I'm your host, Dr. Devi Nair. I'm cardiac electrophysiologist from Jonesboro, Arkansas. And today, we will be diving deep into a topic that's at the forefront of cardiac electrophysiology, pulse field ablation, or PFA. Is it the next big thing in cardiac ablation, or are the safety concerns too significant to ignore? Our episode today is titled Pulse Field Ablation, Safety, Myth or Reality. To discuss this, we have two esteemed experts with us, Dr. Amin Al-Ahmad from Austin, Texas, and Professor Christian Heeger from Germany. Welcome, Christian, and welcome, Amin.
Welcome, Amin.
Now, before we get into the crux of today's discussion, I think let's set the stage. I think pulse field ablation, or PFA, is a novel, non-thermal ablation modality that's gaining traction as an alternative to conventional thermal ablation techniques like radiofrequency ablation and cryoballoon ablation. And we know that PFA uses these ultra-rapid electrical pulses to achieve myocardial tissue ablation while aiming to minimize collateral damage to nearby structures such as the esophagus and phrenic nerve. So I'll start with you, Dr. Heeger. Can you give us a brief overview of what makes PFA different from the traditional methods and why it's, being as a potentially safer option?
Yeah, it's first of all, I would like to thank you for the invitation to this podcast. So thank you very much. And of course, I would like to answer your question. So with PFA, for the first time in the field of cardiac ablation, we have a non-thermal energy source. So PFA is non-thermal, so we don't use heat or cooling. So we destroy our targets with pulse field ablation without any heat and cooling. So the big advantage is that different tissues have different thresholds for PFA energy. So the threshold for cardiac tissue is very, very low, and you can easily achieve ablation in the cardiac tissue cells. But the threshold for other tissues like nervous tissue or smooth muscle cells is much higher. So you need a lot of more PFA energy to target these tissues. So with these special features of PFA, we have the ability to ablate only cardiac tissue and sparing all the other tissues around the heart, and we don't injure it. So only the target area. This is the special thing with PFA.
Thank you, Dr. Heeger. Now, with any new technology, safety is paramount, like you said, and you alluded to some of the technical aspects of PFA that potentially could make it safer. Now, we've had multiple IDE trials that were published in the last year, the ADVENT trial, the PULSED AF trial, the SPHERE Persistent AF trial, all directly aimed at comparing PFA to conventional thermal ablation techniques in a wide variety of AF patient populations. And the results were definitely promising in these trials, showing comparable efficacy and some potentially fewer complications. Dr. Al-Ahmad, you've been involved in some of these pivotal studies around PFA. What are your thoughts on the safety profile of PFA and what these studies showed when we compared it to our conventional technologies?
Yeah, thank you. Thanks, Debbie, for the opportunity to discuss this important topic. We've been involved from very early on with the different technologies in the clinical studies in Austin, our center in Austin. I've been personally involved with several of these. the studies really did demonstrate a very good safety profile for PFA. Now the study numbers are not really large enough to look at things that happen much less frequently, like fistula, but it's very reassuring that none of it occurred during the study. The things that did occur during the study are the kinds of things you might expect with any type of an ablation procedure, where you might have some effusions and vascular complications. Importantly, there's been registry data also that has really validated what Dr. Heeger said, which is that because it's a non-thermal energy source, we're not seeing the collateral damage that you might expect to see with a thermal energy source, in particular things like the esophagus and the phrenic nerve. That does not seem to occur, at least in very large registry data with thousands and thousands of patients. Where you might expect to see a small signal if it did occur, we're not really seeing that. So it's really very reassuring from my perspective as far as the safety data with PFA goes.
Thank you, Dr. Al-Ahmad. Now, you brought a great point, the real-world data, right? The IDE trials, we know, are very well controlled, lead operators who've had, a lot of experience. But, Europe has had this technology for quite a number of years, and they've done a phenomenal job bringing together some real-world data through the Manifest PF data, the Manifest 17K, and the Euphoria registry. And Dr. Heeger, you've had this technology for a while and were part of some of these registries. To me, I think the real-world data is very, very important, especially once you have it in the hands of all operators. How do you see or view this, the current landscape of the clinical trials? Do you believe the data we have so far is sufficient to declare that PFA is a safer alternative, or do you think we need more evidence?
Yeah, thank you very much for this question. So with Manifest 17K, we have a very, very large and interesting study. So 106 centers from Europe and more than 17,000 real-world patients were included. And there were no esophagus lesions, no PV stenosis, and very rare other complications like phrenic nerve injury. It was just transient. And so the data is excellent. So for me, to get it into the EP community, we don't need more data concerning safety. So the safety data is excellent. Pericardial tamponade, of course, we have some, but this is most likely not related to the PFA technology. The same with vascular events, most likely not related to PFA. And of course, we have to talk about coronary spasm and also haemolysis, but also here the rates are so low that I don't see any big disadvantages concerning safety of PFA. So US, they already started, and I think they can be safe and can start it very, very large.
Yeah, and I think, thank you. And Dr. Al-Ahmad is leading the Disrupt AF registry, which is going to look at real-world data from the US as well. So more data to come. And I think those are important points because, the procedure is done so differently in the US versus Europe with the technologies that we use with integration of ICE and mapping in the US quite a bit. So it'll be really interesting to see how all of that plays out. I think practically in my mind, when we used to do AF ablations, things that we used to worry about, the esophagus, the phrenic, those are not our concerns anymore when it comes to PFA. Dr. Al-Ahmad, I want to kind of bring it back to you. Are there certain specific risks or complications that you think are unique to PFA that our listeners need to know about and watch out for? Since we're saying it's safer, but I think there are other things that we need to discuss.
Yeah, I think absolutely. And in fact, interestingly, some of that registry data allowed us to see some of those complications in Europe and make some adjustments. For example, using the larger sheaths that you might use with PFA, there is a risk of air embolus, and once that's managed correctly, that risk can be reduced quite a bit. And similarly, the risk of tamponade, as was alluded to earlier, is not really a risk of PFA per se, but changing the type of wire you use and things like that are lessons we learned from Europe. I would say the one thing we do consider to be a specific risk of PFA potentially is the issue of hemolysis, and if excessive hemolysis exists, then potentially renal failure or increase in creatinine, things like that can occur with that. That's something that we've started to see, but really once you understand it and understand how to minimize it, I think it can be managed fairly safely.
Ready to elevate your skills in electrophysiology and cardiac rhythm management? Don't miss Rhythm Interventions Online 2024. Engage with top experts, discover the latest advancements, and network with peers from around the globe. RIO is hosted by Dr. Devi Nair, course director and host of the Rhythm Interventions Unplugged podcast. This is your chance to ask questions, gain new insights, and deepen your expertise. Our world-class faculty will be live from November 20th to 23rd. Register now for free at riocongress.com.
Dr. Heeger, anything from your real-world experience that you do differently from how you used to do your thermal ablation techniques?
So in terms of the Manifest 17K registry, it was based on the FARPulse device, which is currently the most used device for PFA. There are several others, but currently most of the data is based on the FARPulse system. And to be honest, the usage of the FARPulse system is very similar to use a cryoballoon. And so I use this system equally to a cryoballoon system without any contrast applications to see the sealing of the vein, of course. But in terms of the usage, it's a very, very straightforward, simple and fast procedure. So I use it like the cryoballoon before, but it's more safe, more effective, more simple, and more fast.
Yeah, I completely agree. I think that's been our experience as well. I do want to really quickly touch on the issue of coronary spasm as well, because there have been case reports of coronary spasm, and we have been pre-treating our patients with nitroglycerin, especially if you're in the vicinity of any kind of coronary arteries. Is that been your experience, Dr. Al-Ahmad?
Yeah, we have not experienced any episodes of coronary spasm. So there's some specific areas where if you ablate, for example, in the mitral isthmus area near the left atrial appendage, or on the right side near the tricuspid isthmus, you could be close to some of the coronary arteries. And pre-treating is very reasonable in those situations, in particular if you're close to the arteries. One of the ways you could do this is you could look with ice and determine how close you are, or you could simply pre-treat. I would say in our experience in Austin, some of our folks pre-treat, some of them don't pre-treat, but we've not seen any. I think if it fortunately does not occur very frequently, but I think in general, it's probably better to not be on the tail end of that and maybe think about it before it occurs rather than wait till spasm occurs and then you're having to treat somebody who has a spasm.
Yeah, those are all great points. Just to bring it all together, Dr. Heeger, for our audience, for our listeners, what advice would you give to the electrophysiologists and the clinicians regarding a safe implementation of PFA, as many of the U.S. physicians are just starting to bring PFA into their clinical practice?
So first advice would be stay to the indications. So I would, with the FARPulse system, I would only do pulse field ablation of the pulmonary veins and not usage for any mitral line or anterior line applications, because we see this spasms if we do ablation of a mitral isthmus, for example. So stay to the indications and, of course, have fun with it. It's a lot of fun.
Dr. Al-Ahmad, any final thoughts for our listeners? I mean, it is... you've kind of summarized everything, but just any final thoughts on what they should be mindful for?
Yeah, I mean, I would say the big things we learned were management of your sheath is probably paramount. With respect to spasm, I think treating is probably pre-treating is a good idea if you're close to an area or if you're concerned about it. And then with respect to hemolysis, I think the idea is that most of these patients, you will see hemolysis, but that doesn't necessarily translate to kidney failure or anything like that.
Well, thank you, Dr. Al-Ahmad and Dr. Heeger, for sharing your insights on this critical topic. I mean, it is clear that PFA holds great promise. We are in a new era of treating atrial fibrillation, but it's still early days. We've heard a lot from our panelists today on the safety aspects of pulse field ablation, but also some of the unique challenges and unique things that we need to keep in mind as we implement this into our clinical practice. So to our listeners, thank you for joining us today. As always, stay informed, stay safe, and we'll see you next time. Thank you.
Thank you, Devi.
Goodbye.
That's all for this episode of Rhythm Interventions Unplugged. Never miss a beat. Make sure you subscribe to the podcast and please share your thoughts with a review. We'll be back next month with another episode. Until then, keep the rhythm going.